let me just turn down this thing here. Okay. All right. So yes. Okay. So this afternoon we're gonna discuss about the biostat and let me tell you. I mean, before the afternoon session start, let me just tell you one thing. Biostat in is heavily depend on if the Dr. Acuna, you know Dr. Acuna, right? If Dr. Acuna teaches you, that's going to be very different from what you need to learn or what will be on the step one exam. Okay, so I have to tell you that it's kind of it's very how can I say, like ironic condition that if Dr. Akuna teaches, if somebody else teaches, somebody else teaches the biostat and epi, that will be very different from Dr. Akuna's. That's what I say. Okay. So if Dr. Akunas teaches you, then it will be different game. I wouldn't say he's a bad professor. Uh, he's he's a very weird professor. Say, okay, yeah. So it's not what I'm saying is like he's not really mainstay of the what I mean the contents that he's gonna teach is going to be it's not going to be Dr. Acuna. I will not ride on it. uh, no, Acuna, Acuna. Yeah. So it'll be a different game. So yeah. So yeah. Acuna, Acuna. Yeah. So it will be a different game. So, but I will focus on what he is going to teach, and which will be different game. Okay. So, but I will discuss about the like more kind of board style questions rather than Dr. Akuna's specific type of questions. But I will discuss about what he will focus on. Okay. All right. So today's topic is going to be the embryology. Okay, this session's topic, embryology. I will just because this. I think there are about 50 pages of the slides, which I extracted from the bootcamp, the PDFs, and I will just highlight the word that if these are the because obviously you cannot get everything for renal in 50 slides, but I try to the include the pages that you really need. Okay, so some of the pages I intentionally like omit was the particularly can let me just in my pen. Okay, so I intentionally the delete in this slide was the electrolyte balance. So electrolyte meaning that the sodium, potassium, and calcium, magnesium, and that kind of things, right? So this is one session, okay? And then also another session is acid base. I have I think 2 slides in here, but those 2 topics. This is also one session. This is one class, okay? So, but these 2 classes are important. But uh, that that part I just intentionally deleted because it'll be too many pages. Okay, but it doesn't mean that these pages are not important. This is very important pages. Okay, so make sure that you know this, and then the contents that they teach in the acid base is especially very, very important. And then they cover very kind of comprehensive fashion. Okay. So also the electrolyte, it's not important by itself, but I think we in our class, the Dr. Millis taught this the electrolyte class. You know, as far as this electrolyte class, his electrolyte class is like amazing. It's really, really good. You know, it's you have to really digest. I normally don't watch the lectures twice, but this lecture I watched it twice. Really, really good lecture. And maybe you can just download the video and then you can watch it later too. Okay. And also the acid-base class was also one session, but it's highly, highly recommended because they go very comprehensive. So they go beyond what you need in the step one. So I just leave that out intentionally, okay, for that reason, because it's the class is much, much better, right? So for the embryology, I'm gonna discuss I'm gonna just basically I'm gonna highlight the really, really important points in here, okay? So embryology, what you need to know is that I don't want to discuss many, many details in here, okay? I cannot. So what you need to know is pronephros, you don't really have to know because it will become mesonephros, okay? Mesonephros and metanephros you need to know. And the mesonephros is basically temporary. Okay, temporary kidney. So for 1 month, first trimester, it will become a temporary kidney, and then this job will be taken over for metanephros. Okay. Also, another important thing is that for female, this will just obliterate. Okay. Male, it becomes the internal male organs. What are the internal male organs? Can anyone tell what's the internal male organs and then what's the external male organs? It's going to be the preview of the internal male genital organs. I mean, yeah, it's going to be the preview for the next session. I mean, for the repro session. You learn this in when you're in Med 2, right? What are the other? You can just unmute and talk. What are the internal male organs, and then what are the what's the external male organs? You don't know? You don't remember? This is very, very important thing you need to know in the from Med 2, all right? So external male organs.
I'm brain dead, Kevin. Sorry.
What?
I'm pretty much brain dead, not clinically. But it's just good review. Thank you.
Yeah. External organs, okay. PPS. Prostate. The prostate, and then penis, and then the scrotum. All others are internal organs, which include the, I think it's lease. That's what I remember. I'm not sure whether I remember it correctly. I mean, B's, something like that. Vas deferens, the ejaculatory duct, epididymis, and PL. I don't remember. I forgot, but basically other than the prostate, PPS, all others are internal organs. Okay. Right. So you need to know this internal, external organs. Okay. So other than PPS, all the internal male genital organs will be made of from the mesonephros. Okay. So that's what you need to know. And basically mesonephros job will be taken by the metanephros. Okay. So metanephros has two things. Do you know what mesenchyme? What does mesenchyme mean? Mesenchyme, interstitial, stitial, and what else? Like those are basically all, there's an organ and there's the main organs, and then some blood vessels, or the organ tissues and everything that is not the outside of those things. Basically, there are some, say there's a blood vessels, right? Let me use it. There's a blood vessels, and then there's like a liver, there's a spleen, whatever, and then there are some the spaces, right? All these spaces basically is interstitial or mesenchyme, or there are some other wordings. They are basically same thing. Okay, so basically this other than the other than the main structures of this kidney, including the other things. So it basically the what makes up the really organelles or organs. Then other than this, that's going to be all mesenchyme. Okay, so metanephros mesenchyme will make the basically kidney. Kidney means that this kidney, this is a kidney, right? Kidney, and with the exception of a collecting duct. From collecting duct and below is not from mesenchyme. So collecting it becomes like a calyces, and collecting duct is basically at the end of the nephron, right? And then the collecting duct, and then calyces, and the minor calyces, the major calyces, and pelvis, and then the ureter, and the bladder, and urethra, right? So all these things will be just from metanephros. And then metanephros mesenchyme will make up the before collecting duct. Okay, that's what you need to know. All right. So, and another thing, important thing, here mesenchyme, and then this not collecting duct. This part, I don't know why they didn't say hiled. This has to be hiled. Okay. Anyway, so another thing, important thing is that the uropelvic junction, pelvic junction. So ureter is basically kidney, the kidney here, and then this is a ureter, right? And then the pelvic rim here, and then there's a bladder, right? And ureter pelvic junction. Okay, that's the sometimes that this area is very hard, very easy to damage it, because the pelvic is kind of, pelvic basically is a pelvic rim is basically is a bone, right? So ureter is very tiny, thin, like thin hose, very tiny, about my half of my pinky size. Okay, so very thin the tube, and then that has to cross the the bony material. So it can be like blocked easily, and then that if that blocks, then it will become failure to analyze. So if it's basically canalize, I mean, so it has to be open, right? But because of this, the bony material, it cannot go through it cannot be canalized. It cannot, the hole is not there. Then it will become the problem, right? So this is what this means. So that usually happens if you see the newborn baby, his ureter is like blocked. Usually happens in the ureter pelvic junction. Okay, so that's the one thing that you need to know. All right. Okay, and I will just go through this one, this very, very briefly. All you need to know is that this formula right there, right here. Okay, C equals UV over P. What does this mean? What are the clearance? What does clearance mean? Clearance means like clearance sale. What does that mean? I'm gonna get rid of it, right? So clearance means out of body, right? You are just get rid of the from your body. That's clearance, right? Clearance. Think about this. Don't try to memorize the formula, but rather try to understand it. Okay. So clearance, getting rid of the body, is amount of urine, amount of this urine flow. So amount of urine times like what percentage of this material X taken up the urine, right? So that divide by what's in the plasma, what's in the blood. So what happens is, what do you mean, Jonathan? What do you mean by polite? Yeah.
What's in the, what was the question again, Kevin?
No, I mean in the chatting, you said, someone said the polite.
Oh no, don't. That conversation is old.
Oh, okay.
I was correcting
Yeah,
a typo, and
okay.
no one thought it was
Yeah,
funny.
yeah. Yeah. So basically, what this means is that out of this in the blood, right? In the blood, there will be some some material X. Say material X has like there in the blood there may be something else, and then material X may be covering this much of the X is like some percent, right? And then all others are something other than X, right? That's total. Out of that total, how much you excrete out of body in the urine is the excrete the amount of X, percentage of X that is excreted, right? So that is like urine flow, right? Urine flow, total out of urine, and then how much percentage in the urine, that X percentage of the urine, the material X. Okay, that's the how much you are peeing out of the particular substance, which is X. We just name it that. Okay. All right. Yes. That's the unwanted material out of the body. That's the definition of the the excretion. Excretion simply means the clearance. It's the same as excretion. Urine. Okay. So inulin, right? Inulin has a what? Inulin has a what kind of the characteristic for inulin? Inulin is no reabsorption, no secretion. What does that mean? This is important, so I will just mark down here. When you draw the kidney, like the flow of the kidney, like flow of the materials in the kidney, you draw. This is my way of drawing. Okay, so the renal blood flow comes in, right? It has two choices, here or here. Okay, here is the 80% and 20%. Okay, and then this is where the glomerular is, the nephron is. Glomerular, so this will be GFR. Okay, now then this some of them will be reabsorbed and some of them will be secreted, right? And then this part, let me just write it here. This part is filtered, okay? Then this part is excreted. So in inulin, Let me write it in another color. Inulin basically is equal to creatinine. It's a no reabsorption, no secretion. So let me quiz you. 100 particles of inulin comes in. Okay, how many percentages? How many particles will be excreted? Answer choices: 10%, 20%, 30, 50, 100. How many out of 100 particles? How many will be excreted? You can chat. You can write in the 100%. That is, I all of them. That's I originally saw that a long time ago. Then after I drew this, I try to understand this the diagram, and then oh, that was wrong, because okay, that's very common mistake. 100% coming here, right? 80% comes here, and then this is basically going back to the blood. Okay, and then the only 20% comes in here, right? So then inulin doesn't have the reabsorption, doesn't have the secretion. Basically, everything comes in here will be going to the urine. Okay, so the answer will be 20%. Okay, so this understanding this is very, very important. You know, this is a like very common the confusion that people have. Okay, so try to, you have to understand this thing. Okay, this concept very, very important. Now you know the PAH, right? Oh, PAH. How about PAH? Where is the what in PAH has like a special characteristic that only secretion. So no reabsorption, only secretion. So meaning that this one is not there, but still the secretion is there. 80% is going back to blood. Yes, that is exactly correct. Sadia, you are absolutely correct. You understanding this is very important. So one of the, okay, let me just continue that discussion. 80% going back to this blood, right? So if you are dehydrated, what's going to happen? Is do you think the creatine level will be going up or down? If you, I mean, let me put it this way. Dehydrated, yes, dehydrated, true. The problem with the kidney, say kidney is not functioning. So is it going to be the more or less? It's up. It's a more creatine will be there. So that's why if we have a creatine level is a very good indicator about the kidney function. So kidney is not functioning properly, then you cannot come in here. Kidney is not there. So so everything will be just coming to the kidney, but the kidney will cannot take it, cannot filter it. So it will just bypass the kidney and then go back to the blood. So that's why creatine percentage is supposed to be the 20% in the urine, but 80% in the blood, right? So normally, but it's not like that, because because kidney cannot take it. So the blood creatine will be going up. Urine creatine will be going down. Okay? Yes, yes. Yes, that's exactly correct. Okay. So understanding this concept is very, very, very important. Okay. So understanding this will make it very simple in terms of a physiology of kidney. Right? So how about PAH? PAH is like I said, no reabsorption, but only the secretion. So what that means is that PAH is basically coming here 100%, nothing in here. Okay, so how much will be in the blood? In the blood, like percentages, 100%, 100. The creatine, I mean the pH comes in. How many will be in the blood, or how many in the excretion? If the 100 particles comes in to the kidney, how many pH will be in the blood? See, this thing is basically nothing. Everything comes in.
pH is equal to RPF, right? Essentially, yeah.
RPF?
Renal plasma. Never mind.
You mean like this?
Yeah, that's what I was probably.
No. pH is a material. It's a substance that is some kind of the substance in your body.
I
that
know. But
you are confusing with the RBF, renal blood flow, and then the renal plasma flow. pH
right.
is no. This is a pH is a material. It's not the measure. This is like it's not exactly same, but I mean there's a regular formula. PF is the 1 minus RBF or something like that. Okay, so it's just it's kind of related. Okay, it's related, but it's not exactly the same. But the pH is a totally different thing. pH is just like a creatinine. Creatinine is like some substance in your body, right? So pH is same thing.
Phenylalanine hydroxylase, PAH, is not. It is full. It is excreted and not reabsorbed. Is that correct?
Excreted, not reabsorbed. Yes, exactly correct. More precisely, I mean you are correct, but you can say it can filter and the secreted and will be excreted, but will not reabsorb. Okay, so it can be filtered, right? And then if it's not filtered, so let me draw this line here. It comes in here, right? And then it can either not filtered or filtered, right? It will be filtered. Some of them not filtered, okay? And then continue this the blood, and then it will not be reabsorbed. And then here, everything will be the secreted, okay? So here, and then here, but then because even if it goes here, everything will be secreted. So it comes in here. Basically, 100% comes in here, and 100% comes in here. 100% will go out to urine. So nothing in the blood. Okay. Understanding this is very, very important for PAH, and the inulin. Inulin is like basically very similar to creatine, because the inulin is like not naturally. Yes, 0% the in blood. Understanding this is super important. Okay, this is this was like always keep bothering me. Actually, I didn't understand this one long time ago. So I mean, so this is a very, very important. Okay, by the way, so this is not true. Okay, this is not pH has nothing to do with the renal blood flow or something like that. Okay, so this is one of the material, one of the substances that in your body. So pH, I don't think there's any kind of clinical significance for pH in terms of functioning of our body. I'm not sure about that, but that's not the important point. What's the important point is that pH in our body. So I don't know. Maybe we the intake the pH or something like that. Maybe some kind of food, whatever, that we intake the pH, that will not stay in our body. It will just go out to the urine 100%. So nothing will be left. Once it comes in here, then that will be the secreted. excreted. Okay, so that's something you need to know. Also, normally the GF, the glucose is going to be 100% the excreted. 100% reabsorbed. So glucose comes in here, and then the glucose comes in here. It will be filtered and then reabsorbed, and then the whatever is not comes in here will be just bypass all this thing, and then it will not be secreted, and it will be reabsorbed. So glucose, about, this percentage is about same. For all materials comes in here, 20%, 80% rule is usually same. Okay, so 20% comes in here, 80% comes in here, but then the glucose is reabsorbed in here, 100%. And so nothing here, 0% here, and then not secreted, 0% here. So basically, excretion urine glucose is 0 normally. So why then, if it is if it's secreted, there would be a problem in, yes. So then when you heard about the diabetes, right? Then why the diabetes has some sugar in the urine? Because this capacity, of course, everything has a capacity, right? So if the capacity is, capacity of the filtering exceeded, so then that's the problem. So then the sugar will be coming into the urine, because two reasons. If the kidney failed, then the sugar will, because too much. Kidney is not functioning, so it's just that basically the cannot reabsorb, cannot filter, and then cannot secrete it. So it'll not secrete it. So so it'll be just the kidney is bad. That's one reason to have the urine glucose. Okay. That's one reason. Another more important reason, more popular reason, is too much sugar. Because normally, say 100%, 100 particle supposed to come in 1 minute or whatever. Okay, but then if it's 1,000, the sugar particles are coming, the kidney cannot handle. Even if it's a normal kidney, cannot handle. So it's like it will be just coming too much. So it will be coming here or here, and then it will be secreted. Okay, so cannot reabsorb this. The main problem is if it's too much, the reabsorption cannot happen. Too much. Maybe it can reabsorb maybe like maybe 300 particles, but if it's more than 300 particles, cannot reabsorb. Okay, so it will be coming out to the urine. Okay, so that's the problem. Okay, all right. So let me see, where are we? Okay, so that's the yeah. This is basically this one. Probably this one is easy to understand when you see it this way. Let me see. So let me draw the new diagram here. Oh, yeah. What the? Is my okay? I'm not sure why I cannot write in here. Let me write in here. Something wrong with my pen. I don't know what happened with this. Let me just restart my
Kevin, can I ask you something
Sure.
about glucose? The most glucose is reabsorbed to the proximal tubule, correct?
Most what?
Most glucose
Yes.
that is filtered at the glomerulus is
Yes.
reabsorbed
at
the proximal tubule.
Yes.
So much correct. So that it's very, very uncommon for glucose to be in urine, right?
Yes.
It's almost 100% reabsorbed.
Yes. Normally
in
you don't see
in those with diabetes, the problem is the system's overwhelmed, and so therefore the concentration of glucose is too high for all of it to be reabsorbed at the proximal tubule. Is that correct?
Yes, the too much sugar is coming in to the proximal columnar tubule. Then PCT cannot handle.
I understand. Thank you.
So you know the TM. You learned this in med too, right?
TM.
Yes, so maximum. I don't know what T stands for. You know the glucose. This kind of curve.
Oh, T sub M. Yeah,
T sub M, right? So that's what happens. If it's over capacity, you know, the kidney cannot handle, cannot reabsorb. Okay, so everything will be just whatever comes in here. The only some of them, within the capacity can be reabsorbed, but too much comes in, then you cannot absorb it. Why is it too much? If in the diabetes, why the too much blood is too much the sugar is coming in here? Too much sugar, too many sugar particles are coming in here. Why?
Insulin resistance.
Huh?
Insulin resistance of the
yes. Okay, so insulin resistance. Then what? Insulin resistance. Yes, you are correct, of course. Then right. Why? What happens? Why?
So there's a failure of glucose to be taken up.
Taken up by what?
The hepatocytes.
Huh?
Hepatocytes.
Yes, true, but you know, not only hepatocytes, any cells,
muscles, skeletal muscle. I meant skeletal muscle.
Yes, muscles, the fat cells, anything that supposed to.
Well, those are the big three, Kevin. Let's be honest.
Yes,
muscle, fat, and hepatocytes are the big three, right?
Yes. Yeah. True. Yes. So insulin, the sugar comes in, then it has to be taken up because you know basically sugar is a very good source of energy, right? So it has to be taken up to body cells to be utilized to glycolysis and you know the TCA cycle, etc., making many other ATPs to use it as a like energy source. Or if it's too much, then it will be stored, and then it can use to build the muscles or the tissues. So that's the like anabolic function of the insulin. Okay, insulin will just taken up and then to build the muscles, build the cells. Okay, and or otherwise it uses the as an energy source. Okay, insulin is a very I mean the glucose is a very good energy source, right? Good. Yeah. Okay. So if it's not insulin is not there, insulin resistance means the insulin receptor is not functioning. It's not. It register that okay. I don't wanna work with the insulin. So then what's going to happen is insulin is not there. Insulin receptor, even if there's an insulin receptor, insulin receptor is not functioning. So even if insulin is there, insulin will be high because the initially insulin will be high because you know the insulin is not there. So you know I'm gonna send you more insulin. Body will just make more insulin to attach to the insulin receptor and then do the job. But insulin receptor is not functioning. So no matter how many insulin the pancreatic cells made, it's not functioning. Then there's a problem. Insulin will be high, but then sugar is also high, right? Sugar is also high. That will cause the glucose urea problem. And then insulin is not there, so that will cause the diabetes. Okay. All right. So for this, understanding this is very, very simple. Don't make it complicated. So there are basically two things in here or here. So this is afferent and then efferent, right? And then if you basically, this is the situation, afferent, efferent, right? If you constrict this part, what's going to happen? If you constrict this part, blood is not coming in, right? Because you just shut down the door. So blood is not coming in. So renal blood flow. Do you think renal blood flow will be blood flow? Is it going to be high or low? You shut down the door. Nothing can come in. Low, of course, right? And then how about the glucose? I mean the GFR. GFR will be also low, right? Right. So the both will be low, and then what is it? Fractional what is it? F is filtration fraction. Sorry, filtration fraction will be the GFR over RBF or RPF. Okay, so both will be going down, right? Both goes down, then it will be same, right? So if what the another scenario is that that's the one the when this the afferent will be constricted. Another scenario is that if what if the efferent is constricted, what's going to happen? How about in terms of renal blood flow? Efferent constricted, renal blood flow will be high or low? The afferent constriction. And then this is a efferent constriction. Okay. So if the efferent is constricted, then what's going to happen in the RBF? If efferent is constricted, no, actually, that's the little tricky maybe. But efferent, anything constrict, RBF will be limited. Okay, low RBF. Anything because think about it. So you have say two doors, one door to coming to your room, and then you close the exit door. I mean the outside door, and then you close the inside door. You can close both, right? If you close the outside door, nobody can come in, right? If you close your inside door, still nobody can come in, right? So so construction always, even if it's afferent or efferent, doesn't matter. If you constrict, then blood flow will be the low. Okay, so it will be low. How about GFR? This is the key point. If it's the GFR will be, remember, this is a GFR, right? Coming in down here is a GFR. If you close this door, then what's going to happen? Nothing goes out here, right? And then the more pressure will be here, right? It will because it will just block the outflow, so it will be more pressure inside. So that means that the hydrostatic pressure will be high, right? So that simply means that more pushing toward the nephron. That means that the GFR will be high. Okay, so GFR will be high. And so the renal blood flow is low, right? And then GFR will be high. So the filtration fraction will be the low high, so it will be super high. right? So that's all you have to know. Okay, everything else is basically, if you know this concept, then everything else you can figure it out. Okay, all right. Let's go to the we discussed the natriuretic peptide yesterday, right? So I don't want to discuss it again. So basically, this one is more to the like sodium. So sodium and the another sodium basically, let me give you another the big, I mean very important point in here. So, so one thing really, really important to have to know is that let me just cheat a little bit. So I can, where is it? Just a minute. Okay, just a minute. I have some kind of cheat sheet which I didn't include in the include in the here is okay, the difference between the RAS system and the the and it ANP the ANP and the yeah, this thing. Okay, you might wanna write this down. RAS equals sodium increase per volume. Okay, and then whereas ANP BNP is sodium decrease per volume. Because what happened is, this is an important point. Because what happened is, in the RAS system, right? In the RAS, not only the it's basically it's two RAS has like two kind of the things going on. So one is like the aldosterone function, and then the other one function, the mechanism is ADH. It will increase the ADH. RAS will increase the ADH, whereas AMP basically function as sodium only. So which means that AMP is basically function as only aldosterone function. Okay, so AMP is more basically increase the sodium, the sodium in the urine due to the aldosterone effect. But whereas RAS has two mechanisms. One mechanism is due to the aldosterone, which is basically same as what AMP will do. Okay, and then in addition to that, in the RAS system, is also stimulate the ADH. So ADH will function too. So ADH will, what does ADH will do? ADH will basically like the absorb the something to do with water rather than the sodium, right? So ADH mechanism will excrete more water, pure water. Okay, not aldosterone function is basically if you the excrete sodium, then the water will follow, right? So but ADH is basically the something to do with the water only, not the nothing to do with the sodium. Okay, so
Hey, Kevin, can I ask something about this?
sure.
It's related to ADH, and it's always bugged me. The syndrome of
You mean the
inappropriate,
SIADH?
and it
Okay.
increases ADH. Can you talk about that for 1 second, because it increases ADH, but somehow does it increase blood pressure and bring in water and increase blood volume?
Okay, so actually that was okay, that was actually I was gonna tell that too. Okay, all right. SIADH, syndrome of inappropriate ADH, meaning that basically, in very simple term, too much ADH. Okay, so what's going to happen is that the ADH is going to be blood. So if you have too much ADH, by the way, let me just finish this one first. So basically, this mechanism means that inhibiting. Okay, so don't get confused that this is inhibiting this, inhibiting that. Okay, right? So anyway, so ADH is increased. So ADH will, what does ADH will do? Water,
brings
right?
in salt. Brings in salt.
No, 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 no,
We-
no, no, no,
We
no. This
retain.
bit, I just explained this to you.
You don't lose salt and ADH,
Okay,
antidiuretic.
okay. Let me
You
tell you this.
retain water. You
Okay,
retain water.
let me tell you this. Forget the salt. ADH, nothing to do with the salt. Aldosterone,
It's, I know, it's a way
aldosterone
of
has to do
thinking.
with the salt. Then water will follow, right? But ADH has nothing to do with the salt. Only water. Aquaporin means that only water. That's a key
Okay,
point. Very important point. ADH, nothing to do with salt. Okay? Only water. Okay? All right?
I hear you.
So, yeah. Water only. Let me write down only. Water only increase. Right? Water increase the water. So what's going to happen in your body? Volume increase or decrease?
Increase.
Yes, volume increase. Volume increase, then means your preload will be increased, right?
Yes.
Preload in your the heart is increased. Then do you expect the high blood pressure or low blood pressure?
High.
Blood pressure high, right? Okay. Now here's the key point. Although this blood pressure is high because of the preload is high. Now the problem is there is the ANP. If this the preload is too high, then ANP kicks in or BNP kicks in. Okay, those are the peptide that is located in the heart, inside of the heart, and detect whether they are too much blood is coming in or too little blood is coming in. Okay, so ANP is the detecting, oh, too much blood is coming in. So ANP will or BNP will be secreted. Then what's going to happen is this will be going back here. Oh, here, yeah. So it will decrease the
It vasodilates, right?
no, this is not vasodilate. This will
Okay.
basically the excrete water in, I mean, excrete sodium in water, urine. Okay, so whenever sodium is involved, water always follow. Okay, sodium in the urine, that means water follow. Water in urine too. Okay, so that will make feedback to this mechanism. So that will make euvolumic. Euvolumic. Okay. This is a
Right.
very, very.
That's the thing that's been confusing me. You've
I
only
know,
made,
I know, I know. Yes, I totally
so you're
agree.
saying ADH goes up, water
Yes,
comes in.
yes,
The body then, as a reaction to that, overreacts with AMP and BNP,
yes, yes, yes.
and then we lose all that water, but it's a syndrome of inappropriate, and the name doesn't make sense, but we then like sort of counterintuitively, we then don't retain water, we lose a lot of water.
Yes, yes. That's immediately, you are absolutely correct. Immediately, immediately when the ADH, SIADH comes in, say, from day one, ADH, SIADH will have exactly same symptom as what you are expecting. In the long run, though, the AMP and BMP kicks in, that will make the like a kind of balance out and feedback to this the volume and the volume increase and preload increase and blood pressure increase. That will kind of feedback. and then that will make the euvolumic. Okay, so you are absolutely correct. And you can argue that, okay, yeah, because ADH has a, like, it will increase the volume and then it will increase the blood pressure. And then why is it going to be the euvolumic? Yes, true. But then the key point is the AMP, BMP.
But oh God, it's another. Euvolumic means normal.
Yes, normal volume.
So why is this a disease if the body compensates perfectly?
I why is it disease? That's a good question too. So
Okay.
what
I didn't mean
happens?
to take up all our time. You can understand why it confused
Yeah.
me. Can you
So what
understand?
happens is here, is a SIADH is normally this is a neoplastic. Neoplastic. Okay, neoplastic means that when there's a like some kind of cancer or something, then this will be appear, right? This symptom appears. It usually SIADH is not really just by itself. It usually accompanied with some kind of cancer, small cell lung cancer or squamous cell lung cancer, usually small cell lung cancer, okay? Usually small cell lung cancer. There are some other cancers. I think it's pancreatic cancer or something like that. Other cancers also has a, it will cause SIADH. I think prostate cancer also has it.
May I say that I think it's just really often used to test us to
Yes,
see
because
whether we know that it
yeah,
increases ADH but does not increase blood pressure.
yes.
Yeah, thank
That's
you.
actually, it's the normally once some stimulation, once some kind of the stimulus here, and then that will say, for instance, like volume increase. I mean, this is, I'm just using just general term, okay? Volume increase, and then there is the mechanism in the feedback mechanism of the body that will decrease the volume, right? Feedback, normally feedback is not as high as the volume increase normally. So at the end, you will have a volume, still volume, it was like volume increase big time. Now because of the feedback, negative feedback, your volume will be reduced, not a little bit, not this much, but it will become volume is a little bit decreased, a little bit increased. That's normal situation, right? Normally, this is a kind of negative feedback mechanism. But this normal the normal negative feedback mechanism, with the exception of the SIADH. You can just say kind of that way. Okay,
I
so
got you. It's
SIADH.
a little increase, but not very.
Yeah, yes. Little increase. So it's actually euvolemic is I think euvolemic is like little bit about the kind of misnomer, because I still don't think this will be just a normally totally the same volume, normal volume. I think this still has to be little bit about the, if volume increase was like say the 100% volume increase, probably it will be probably like maybe I mean it was like 100 was normal, and then it will say increase 150, right? It will be probably maybe 110 or something like that. Okay, that's what I would understand, right? But in the exam, you will say euvolumic. Okay, because of the region is AMP, BMP, all right? So you will, but still things that euvolumic. How about in terms of salt level? That's the key point, that it will not be the like normal. If you have a SIADH, you will not be normal person, normal healthy person because of this thing. How about sodium level? Is sodium, do you think sodium level will be low or high in the body? And then the body, blood, and then the urine. How about urine? What kind of urine do you expect? Urine, is the urine going to be concentrated or the diluted? That's the key point. Urine will be concentrated. Okay, I'll just write down in here. Urine, the concentration, concentrated. Okay, urine will be concentrated, very thick. The urine. Okay, so little urine, thick urine. Okay, so that's the key point. Your volume will be they say the U volumic, but I think it has to be like instead of 100 to 150, it will probably increase 100 to maybe 110. Okay, but you in terms of the wording in the exam, you will have to say U volumic. Is it because of
I've
the
also seen it as hypovolumic.
yeah?
Hypo.
So hypo? I don't think so. That's wrong. Hypo? That's wrong.
Yeah.
No, it
Okay.
cannot be hypo. Either
Okay.
it can be euvolumic or just very, very slightly the hypervolumic, not never hypovolumic. That's impossible. That's
But
not
to
possible.
sum up with the SIATH,
Right.
it's fair to say it's a little tricky, right?
Yes, true.
Okay. I didn't want
Yeah.
to hold us all up
Yeah,
just
yeah, 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 yeah,
because
yeah. Good
I
question. Yeah,
find it
good.
tricky.
Yeah, yeah, good question. But I have the same. I had the like, same question too. But it's still, it's in the exam purpose, you have to say euvolumic.
Okay,
Okay.
thank you, Kevin. Thank you.
Yeah, that's what I had to say. All right. Now this is a acid base. Okay, acid base is like I just included only 2 pages in here, but I want you to read this in focus on the lecture that they will give you for only one class. Acid base, very, very important class. Probably you might wanna when you have that lecture, you might wanna download it, and then also Dr. I'm not sure about this, but Dr. Dalmeda will post the acid base the like maybe she call it like premiere or something like that. I don't know why that's premiere, but the premiere videos like 6 or 7 like 30-minute videos. Okay, watch that before the class. Okay, I highly recommend this. If you don't watch this and then take that particular class, it will be very, very hard to follow. Okay, so watch these videos, premiere videos. She will when you post it, when she posts the video, she will email you. So watch this video before the class. Okay, highly, highly recommend. This is really worth it. Okay. All right, so I'll just the skip that part. Okay, for it's better for you to watch that video because it's only one class, and then very high, and then if you understand that fully in that particular class, you are done with the acid base because acid base is a kind of popular topic in the USMLE, right? Okay, so once you understand it, it's it will be you are good. Another important topic is among this the acid-base imbalance. One important topic is metabolic acidosis. Okay, metabolic acidosis is important because it has many associations. Okay, so one of the particular association is this DKA. Very, 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 very important. Okay, and then uremia, other things are also important too. But the DKA, pay attention to this DKA. Very, if you understand this will be very, very helpful. Okay, so you need to understand what's anion gap. Anion gap simply means that anion, right? Anion anion. Anion, so anion means it, the negative ion, right? So negative ion gap. What does that mean? So it means that
Usually too much chloride, right?
um
No.
not necessarily because the anion gap is the basically positive charge minus the negative charge. So sodium minus chloride minus HCl. I mean the bicarbonate, sorry, right? So this is an anion gap, the formula. Okay, so they sometimes use the potassium, but most of the time, at least in the AUA, they don't consider the sodium, I mean potassium included in this formula. Okay, but sometimes they use the potassium. But this is the anion gap. Okay, anion gap means this thing. Okay, so it's not necessarily chloride, but actually more to do with the bicarb. But it's actually this can happen anywhere. Okay? Sodium or the chloride or the bicarb. Okay, so what happened is if that is anion gap supposed to be like the 12, 8 to 12 is normal. If it's beyond, if it's like the 20, that's the problem. Okay, so the causes that makes up the anion is the mud piles. But this is like methanol, uremia, and the DKA, and then this thing. But better option, maybe the newer option is coming in another. Let me see. Med for another. Let me see if I can find the anion gap. Anion gap. Then there's another mnemonic that that's probably better for you to understand. Let me see. Yeah, right there. Right there. Gold mark. Okay. This is the newer version of the newer version of the anion gap. This thing is, I think this is the more making sense. But actually, the my own mnemonic is probably better to understand, which is the Galmac. Galmac. Okay, so what Galmac instead instead of Goldmac, because it's Goldmark is it's okay, but there are some the mnemonics that which is not really kind of it's not hard to remember. Okay, so this is probably easier to remember. Glycols, ethylene glycol or propylene glycol. Okay, glycol G, and then A is acetaminophen, and then they say the acetaminophen in the where is it? Yeah, they said O. What does O has to do with the acetaminophen? I mean they have oxoproline. Who uses the oxoproline wording? That's almost like non-used. So, acetaminophen is much makes sense, right? So acetaminophen, and then lactic acidosis, and then methanol, and then ASA, the aspirin, and then the C is chronic renal failure instead of like a renal failure. Okay, and then the K is a ketone, so DKA. Okay, so use my mnemonic Galmac. Okay, so I think this is a better working better. Okay, so Galmac, use the Galmac as the mnemonic. Okay, so instead of this Galmac, if you want, you can the screen capture this thing if you want. Right. I mean, I'll just make it this way. Yeah, screen capture this way. Okay. All right. So in those conditions, okay, anion, if the metabolic acidosis is caused by those conditions, that's called anion gap metabolic acidosis. Okay, MAGA, anion gap metabolic acidosis. Okay, so or metabolic acidosis caused by anion gap. All right. So this is like the kind of summary table for this, acid-base imbalances. Okay. So why does the diabetic ketoacidosis occur? DKA. What happened? What happened to the
Due to beta oxidation,
what?
due to fatty acid breakdown in lieu of glucose?
Yes, true. Yes, so fatty acids, beta oxidation will make the ketones, right? So, what are the three ketones?
The names of them.
Yeah. So what's the ketones? Like,
I would know them if I saw them.
acetylacetochroic and the beta hydroxyl the CoA, and then acetone, right? So all the out of the three things.
There they are. There they are.
Yeah. What's the thing that is in the gas form, which is acetone? Okay, acetone is in the gas form. Why is it important? Because acetone is not involved in the blood. It has nothing to do with the blood. It will you will breathe out. If it's too much the ketones, you will have to excrete the ketones, right? So you cannot see acetone in the blood. You cannot see acetone in the pee. You will see the acetone in the gas. What that means is that you will breathe out acetone. So, have you ever have you ever been the nail salon? If you go to nail salon and then they do the nails, right? And then they do nails, and then if you sometimes you have to kind of remove the nail, right? So acetone remover, right? And then if you the close and then the smell, you feel like a kind of kind of fruity smell, right? So that's what acetone is, okay? So acetone, you breathe out, okay? So what happens is in the DKA, let me just briefly go over DKA mechanism because there are other things to discuss. You have too much the sugar in the level, in the blood, okay? Basically, diabetes means too much sugar in the blood, right? So why is too much sugar in the blood? What happened? But this is not actually sugar in the blood is not really a bad thing, because you have like sugar. You need the sugar, right, to make energy. You need the sugar to build many things. So sugar is a good thing, right? The problem is if it's too much, that's the problem. Why is it too much? It is too much because of this is a problem. This is not a problem because no insulin is working, not working. Not is make sure that you understand this one. Not working. It's not because of the insulin is not there. Okay, insulin not there. There's two different things. Insulin not working. Okay, let me make it clear. This is a type 2 diabetes type 2. This one is a diabetes type 1. Okay, insulin not working is a type 2, and then insulin not there is a type 1. Okay, so what happens is in the type 1, you don't have insulin. You don't have insulin, so here's a blood vessel and sugar. Insulin's job is to bring this in the insulin we're supposed to bring this into the cell. So cell can make the go through the glycolysis and the TCA cycle, ETC, and making a lot of other ATPs, and then use it as an energy source. Or you go to another path is that the insulin is another path is to make the build the cells, build the tissues. So anabolic functions, right? So that's a really good thing. But insulin is not working. So insulin, even if insulin is there, doesn't work. So sugar level will be very high. Okay. So cell cells body don't care about the whether there's like a lot of blood vessels. I mean, a lot of sugar in the blood vessel. Body cannot detect. So what body will react to it is in terms of cells. Okay. In the because why the body cannot detect in the there is like a lot of sugar. Body cannot detect. Why? Because blood vessel in kind of the very very general term, blood vessel is not really part of the kind of outside the body. You know what I mean? It's kind of because it's basically cells is inside of the body. Blood vessel theoretically kind of outside the body. Okay, so body cannot detect it. So all body do is like the detect through the like cells surrounding the blood vessel rather than inside of the blood vessel. Okay, so um so cells don't see the sugar. So irony is that the problem with this diabetes, sugar in the blood, and then the no sugar in cell. This is the problem. No sugar in the cell, that's the diabetes. Okay? Understanding this is very, very important. Not, oh,
Kevin,
sugar in the, what?
type 1 diabetes presents in children, right? What age?
Usually type 1 is the basically it's a kind of autosomal recessive, I think. Yeah, it's a kind of genetic condition. The pancreatic beta cell will not make the insulin because there's like autoimmune.
But
So
it's unusual for adults to get type 1, right? It's more of a, as you say, autoimmune or
yes,
genetic.
because it's type 1 is usually the children's or the juvenile syndrome because it has something to do with the autoimmune.
And you don't know what age it starts in
Oh,
children? Is it at birth?
it will start young age in the usually kid and the kid and juvenile.
Okay, so
Yeah,
at the childhood illness.
yeah, childhood, right. So what happens is that because what happens is in the very very young age, right, like 2 years old, 3 years old, the immune system is not there. Immune system is not well developed. So what that means is that they are also like vulnerable to the infections too, right? But also on the other hand, they don't have a lot of the autoimmune diseases because autoimmune disease. In order to have autoimmune diseases, your immune system has to be kind of intact, right? So your immune system is not intact, so you don't really see much of the autoimmune disease in very young ages. Like 3 year olds, have you ever seen the 3 year old suffering from SLE? Very, very rarely. Okay, because it's their immune system is weak, meaning that their immune system is not strong enough to attack yourself. Okay, so that's why you don't see much of the autoimmune diseases. So diabetes type 1 is actually autoimmune diseases. So you don't see them in very young age. Okay. So that's why it's like a kind of the young age means that like maybe 10, maybe that age, 10 to maybe the 15 or 20 maybe. So that the kind of the usual age that has the type 1 diabetes. Okay. Anyway, so
It's a little bit of a double-edged sword because you don't have
what
an immune system. It's a
what?
little,
Yeah, 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 yeah.
it's like a win-lose for the baby,
Yes,
for
yes,
the
yes, yes.
kid.
True, 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 true. Right. Okay. Anyway, so what happened in the diabetes is a key point is that the cell don't have a sugar. So what the cell will do? Cell will try to make sugar. I mean, make not the sugar. Yeah, make glucose, right? Yeah, glucose is sugar, but make glucose, right? So make glucose from the other sources, meaning that you can break down the glycogen, but which will be lasting only 2 days. Then next target is going to be GNG, glyconeogenesis. Glyconeogenesis is basically breaking down the kind of other non-glucose things. So like from fat, from protein, those things, right? That's the glyconeogenesis. So new glucose made, right? So it will make the GNG. It will do a lot of GNG. Okay? During the GNG, then if it's not enough, then they will to make the if GNG is not working, then it will do the making ketone. Because even if the glucose is made through the GNG, right? But that's not enough. That cannot support if it will make more, it kind of it will make more sugar in the blood, right? Blood vessel, right? In the blood vessel, but still insulin is not there, so cannot cannot intake the sugar into the cell. So cell still GNG doesn't help. So it will make
Well, Kevin, only in adipose tissue striated muscle. I'm reading off the little thing I posted in the chat. Only in things that require insulin dependent transport.
Yes, true. Yeah, because they are the main thing. I'm just explain this to in general term. Yes, you are absolutely correct. I don't disagree with you. So just you're absolutely correct. But
I can take over the lecture. I'm just joking.
No. I mean, what I'm saying is like in your body, whole thing as a whole, the basically the glucose, I mean, insulin dependent the glucose intake occurs in the big cells like the hepatocyte and fat cells and those things, right? Those are the main resources for the glucose usages. Okay, so glucose, if the cells don't take the insulin into, I mean glucose into the cell, that's the diabetic condition. Okay, so still, even if GNG occurs, cells, I mean this cell don't see the glucose because the problem is not because of the lack of sugar, lack of glucose. Glucose is not enough. You have tons of glucose in the blood vessel, but simply that glucose cannot come into the cell. That's the problem. Okay, so what body will what body will do is make ketone instead of glucose. I mean, instead of glucose. Yeah. So ketone is kind of kind of last resort. Okay. So normally you don't make a ketone. Ketones will be made only if you have a hypoglycemic condition. So your body cell will see, oh, I don't have a glucose. Even if there are many glucose in terms, when you measure the glucose, you will see a lot of very high glucose because sugar level here, many sugar particles in the blood vessel, not in the cell. You cannot measure anything in the inside of the cell, right? So body will make a ketone. Ketone is made by the fat cells and those things, right? So ketone genesis, right? Ketone will make this the three types of ketones, right? So it's a fatty acid is breaking down into through the beta oxidation. That will make the ketones like this thing. Okay, so ketones are made. Too much ketone will be made, right? So then you will have that's called diabetic ketoacidosis. The symptoms are very high levels of the glucose, blood glucose. So your blood glucose normally supposed to be the 80 to 100 is normal. Now the blood glucose level is, if you measure the blood glucose, it's like 500, something like this. Very super high. So What does it mean? If your blood glucose is very high, so you have a many glucose sugar molecules in here. So what's wrong with it? Actually, there's nothing wrong with the sugar molecule being high in the blood vessels. Nothing wrong. Only one thing wrong is that it will cause the non-enzymatic glycosylation, NEG. Very important concept. What does non-enzymatic glycosylation mean? Non-enzymatic, easy, right? No enzyme involved. Okay. Glycosylation simply means you understand when you have like for instance sugar water or some juice or something like that, right? So if you let it just outside for a long time, or if you spill sugar, very high content sugar juice, and then in the like maybe some sink or something like that, and then if you don't wash it, and then what's going to happen? That what happens to that other side? Sticky, right?
Does it fall out? Oh, sticky.
Yeah, it's a sticky. Sugar is very sticky, right?
Yes.
Exactly. The non-enzymatic glycosylation is very scientific term, but you can just make this as a sticky. This thing, same, exactly same thing. Nothing really, nothing more, nothing less. Non-energy is sticky. Okay. So what happens is
Sticky blood. Sticky blood.
sticky. Yeah. But what happens is okay. What happened to the blood vessels? If you the blood vessels is sticky, what's going to happen? Thick blood. Yes. And what's going to happen is, let me draw this thing here. If the blood, this is a blood vessel, and then this is cell, and then there's some receptors here, right? Right. So what happens is many there are channels and there are receptors and there are many things in here in the this is blood vessel, and because this is the kind of communication channel, right? This kind of communication channel, right? So it can be like maybe there's some important nutrient or important enzymes or hormones that will just bind to here and then do some action in the cell, right? But if this is a sticky things, sugar, I mean the juice will be dried up juice will be just fill up this space. Like dried up juice will fill up this space, block the channel, blocks the receptors, blocks, and then also block everything here, and then also narrow down the narrow blood vessels, and then block receptors, block channels, and then also it's a narrow down blood vessels, so blood flow decrease, and then also blood becomes the blood clot can occur. Because the blood flow is the decrease, then blood flow will decrease means that blood flows slowly, right? Slow blood flow. That will cause the blood clot, right? So all kind of things happen because of stickiness. Okay, that's the mechanism of the diabetes. That's the damaging part of the diabetes. But does this really a concern right now? Diabetic ketoacidosis is a very acute condition. Okay? It's not like the chronic condition. This is a chronic condition. Okay, but this is not the acute condition. Acutely, ketone is too much. Okay, that's the like the acute condition. In that acute condition, you will have because you don't have energy source because of the this occurs, ketogenesis occurs only when there's a low blood level experienced by the cells, not blood vessels. Cells, okay? Cells don't see any blood sugar. That's the problem. That's why the ketone is made. Ketogenesis is the occurring. So you don't see because cells is kind of dying, basically. Cells, oh, I need energy. I don't have energy right now. That's the problem. That's the manifestation of the the diabetic ketoacidosis. Now, question is that, so if you basically ketone, the symptoms, signs and symptoms is due to low glucose in cell. This is a key point. Okay. Don't try to memorize, okay, the ketoacidosis signs and symptoms and this. That's like a, you don't understand that. You will not understand if you just try to memorize it. This is the mechanism, okay? So if you don't see in the cell blood, if you have a low blood glucose in the cell, that means that basically hypoglycemic conditions. Although you will have the hypoglycemic in the blood vessel, doesn't matter. What body will react to it is that the hypoglycemic condition in the cell. Okay, so hypoglycemic condition, you will have a sweating, you will have a like tachycardic, and everything will be understandable, right? Because you don't have you don't have the energy, so body will try to say that, okay, I need more energy, more energy. So the body will try to, okay, so I just pump more blood to you, and then pumping harder and pumping the faster to supply more blood to you, right? So that's the tachycardic. And then sweating is because of the body experience like low energy. So oh, something wrong with my body. So I have to kind of do something, the fast enough. So the sympathetic will be shoot up. So that will make the sweating. Sweating is one of the sympathetic functions, right? So everything here can be explained as hypoglycemic, not hypoglycemic. Hypoglycemic condition can explain all of the symptoms of the diabetic DKA. Okay? Understanding this is very, very important. I just explained to you, probably very, very simple term, but this is the way to you understand. Instead of try to memorize all the symptoms in the diabetic acidosis. Okay. Another key point is that, I told you about the acetone, right? If acetone is only unique in the ketoacidosis, because the acetone has to be too much. Let me just a little bit add this one. It's a hypoglycemic condition plus hyperketone condition. Two conditions will have all kind of DKA symptoms. Okay, very, very important concept. All right. So if you have too much ketone, you have to get rid of it, right? You know how you get rid of it?
You'll become what? You'll become what?
Too much ketone. You have to get rid of it, right? Too much, anything you have to, too much, you have to get rid of it, right? So you have to get rid of the ketone. The problem is that the only thing you can urine more in the through the ketone, through the urine, but another thing is that because acetone is not you can get rid of the through the urine because it's a gas, so you have to breathe more, right? So how do you call that kind of breathing? Kasmal breathing. Kasmal breathing. I think my spell is terrible. Okay, Kasmal breathing. Deep, fast breathing. That's kind of breathing. Okay? That's the Kasmal breathing. It's a very unique in the keto DKA. Okay? So Kasmal breathing. So that's like that's how it works in the DKA. Okay. So
big picture, Kevin. Big picture. Well, now you're going right where I thought. Never mind.
what?
I think you're going to what I was about to ask about. So thank you.
Yeah. So
Never mind.
basically, this is the things that you need to know about I explained like more time to explain the diabetes, because the diabetes is a really big thing in the kidney pathologies. Okay, so you have
Well,
to know
wait,
this.
Kevin, I'm gonna ask you. So what does it tend to, does it intend to increase carbon dioxide? Wait, when you breathe like that, you
Okay,
are,
if you breathe it like this, so what's going to happen? If you are breathing more, breathing means what?
if we're talking about, hypoventilating, where your CO2 goes up,
CO2
is
goes up or down?
when you hypoventilate?
Hyper, you hyper.
Hy- Okay,
Fast.
when you
Yeah.
hyperventilate, your CO2 goes down
Yes.
in the body because you're blowing it off so much.
Yes.
So
Okay.
people in diabetic
Respiratory.
ketoacidosis
Uh-huh.
have low, are hyperventilating and have low plasma CO2.
Yes. So, how do you call that symptoms? I mean, how do you call that in terms of acid base? Respiratory what? Alkalosis or acidosis?
Respiratory alkalosis.
Yes. So, alkalosis, DKA was, acidosis, of course, because, the DKA, right? So, metabolic acidosis together, not because of the metabolic acidosis, because of compensating by respiratory alkalosis. No, this is not compensation. This goes together. Okay, that's the important thing you need to know. Okay, together. Okay, although metabolic acidosis, you compensate by respiratory alkalosis, right? That's normal situation. Normally, if you have a metabolic acidosis and you tend to breathe more to have a respiratory alkalosis. However, in DKA cases, both occurring at the same time. Not, of course, there's like a compensation. Metabolic acidosis, your body will compensate by respiratory alkalosis. Yes, true, but in this DKA case, it will occur both at the same time. Okay, all right. So this is just a summary table of the acid base, but I spend more time in explaining the diabetes, the cases, okay, DKA, which is very important key topic that once you understand this, the how diabetes mechanism, everything will be very anything to do the acid base, and then also the diabetes when you in the GI or in the nephrology, which will be very important topic. Okay. All right. There's another thing is kind of the RTA. So RTA type 1. I'll just tell you what's the important thing you need to know is the RTA 1, 2, 3, 1, 2, and 4. There's no 3. I have no idea why there's no 3, but the RTA 1, 2, 3. Okay. 1 is a distal, 2 is a proximal, and then 4 is like a hypokalemic condition. Okay, so I'll just point out which one you need to know. Okay, so because it's kind of once you understand the mechanism, it's okay to the you will understand this. But problem is that this this thing is that it's not very high yield, but the if you try to understand the whole mechanism, that will be too complicated. Okay, so to deal with this the RTA, I normally not recommend you to memorize anything, but in this case, uh, it's easier for you to deal with in terms of kind of benefit and risk. The like, risk being like taking too much time, and then benefit being that you understand the mechanisms. But I highly recommend you to kind of the understand the like basic mechanism, right? Basic mechanism. Then try to like, what's what they asking is like, is the serum level, potassium level going down, or the pH, urine pH will going up. So that's what they are asking, right? So I think there's the table. Oh, it's not there. Okay, table is not there. But the best way to deal with this is hopefully, I'm not sure whether your the PESO teacher will be same as my PESO teacher, but he is like king of the summarization. So he just try to simplify anything, whatever he the explain, he just summarize everything in one table, and or one like drawing. Okay, so hopefully he's the same guy, because what happened is I'm not sure whether you will get the same teacher, because what happened is he is applying for residency this year. So if he matches, then he will probably quit the job. So I'm not sure. But
Dr. Brahma? Dr.
what?
Brahma?
Yeah, Dr. B. I don't remember the name. So
Yeah, he was our facilitator.
yeah,
He's
yeah, yeah,
gone
yeah,
to
yeah. Yeah,
biology.
yeah. If he hopefully he teach, if he teaches, he will just explain this really only the key point that you need to know. Okay. So I will just leave that. It's going to be the only one lecture. Okay, so I will leave that to him. Okay. Okay. Another thing, important thing is because we have only like 10 minutes left. So another yeah, another important thing is that this the nephritic and then nephrotic syndrome. I just write down nephritic and then the nephrotic. Okay. So the difference is that this is a point 3, more than 3.5 the protein urea. Okay. So nephritic and nephrotic is basically this is the main distinguishing point. No matter what symptoms you have, if the this is a kind of criteria, the main criteria. So what that means is that if you have all kind of, say for instance, like I'm just making up the story, okay? All kind of nephritic syndrome symptoms, okay? If we have all nephritic symptoms plus uh, protein level, urea is like more than 3.5, you have to say that's going to be the nephrotic syndrome, not nephritic syndrome. Okay, only so protein point 3.5, more than 3.5 is that defines the nephrotic. Okay, so you have to know this number 3.5. Period. So if you have, even if you have all kind of nephritic syndrome, there's no nephrotic syndrome symptoms. Doesn't matter. If you have, as long as you have a 3.5, then you are categorized as nephrotic syndrome. Okay? So that's something you need to know. Because some of the symptoms are very overlapping. Okay? But 3.5, you cannot avoid that. You cannot avoid, oh, yeah, you have all kind, although you're 3.5, you have all kind of nephritic syndrome that, he could be nephritic syndrome. No. You have to say nephrotic syndrome. He might have some, both nephritic, nephrotic, yes, possible, but not, if you choose only one point, that's going to be nephrotic syndrome, okay? So there's like basically like primary means like direct injury, and the secondary is like due to the other problems like SLE or diabetes that will cause the damage to the glomerulus, and then focal and then diffuse means that this glomeruli. So focal is basically the picture slide. Okay, so this one, that's the focal, right? And then membranous means like there's a like glomeruli has a, not this one, sorry. Um oh okay. Glomerulus has a like the layer. So basement membrane here. And by the way, basement membrane is a membrane. It's not cell. not even a cell. It's a, you know fascia, right? Its basement membrane is basically fascia, okay? Kind of fascia. So it's kind of thick fascia here. And then fascia, uh, before, I mean, this is like the urine, and then this is the blood side, okay? Then the urine side has it's called epithelial cells, and then the blood side is called endocellular cells, okay? So epithelial cells has a kind of this the type of cells. It's called podocyte. Podocyte. In other words, podocyte is epithelial cells. Okay, that's the same thing. Okay, and then the other side is blood side is endothelial cells. Okay, so that's what you need to know. You need to know. So focal is like a pizza pie. Only one part of the glomeruli. Correct. Okay, membranous means something to do with membrane. Membrane means that this membrane has three layers: podocyte, and then endothelial cells. Okay. And proliferative means that basically too many cells are they're generating. Okay, that's the nomenclature. Then cast. Cast means that cast usually occurs. I mean, not usually, always occurs in the tubule. So what that means is that say for instance, if you have inflammation, then something is building up here, right? Because the inflammation, then immune cells will come in, and some the injury to the cells, or then that something will be building up, right? Like like if scabies in your, if you cut, there's some scabies in your the injured side, right? Same thing. It will the build up here, right? That will build up more, and then build up, and then your tubule will be eventually the filled up with okay, there are many inflammatory cells, or many anything, something, it can be the fat, or it can be immune cells, or it can be the red blood cells, or it can be many things, anything, right? Anything build up and then blocks the tubule, right? And then if you try to pee, and then it will just the pee will cannot come in, so pressure will build up. If you want to pee more, and then if you are like straining, I want to pee, then pressure will be going up, and then eventually it will push out the what was blocked, right? And then in your urine, you will have this whole thing similar to kind of exactly, this is a picture. Exactly like resemble the tubule. Okay, so it was like this was blocking this part was blocking the tubule. Okay, this whole thing will come out. Okay, this kind of rectangular shape. So that is called cast. Okay, so that in term by urine analysis, and then if you the see the some the what you see in the cast, you will see, oh yeah, what kind of disease you can have, what kind of disease you are having. Okay, so it can be granular, it can be fatty, or it can be fine, higher in the cast. Okay, so that's the like definition of the cast. Okay, and then there can be also, there could be some cells too, right? So like it can have like the red blood cell cast, or white blood cell cast, or waxy cast. Okay, so depending on like what kind of cast you have the like different disease. Okay. Also, another thing is that the like what like big difference between the nephritic and nephrotic syndrome in terms of symptoms is obviously, this is like a key defining point. Okay, you need to know this one. If anything, like I said, if any all symptoms, but if you have this, that will be nephrotic syndrome. Okay, something you need to know. So and the the nephritic syndrome is basically some damages. Some inflammation. Something to do with the nephritic. It's an in full term for nephritic is nephritis causing the glomerular inflammation. Okay, nephritis, meaning that inflammation. So it has to have inflammation. Okay, so that's the thing that you need to know. And like I said, proteinuria less than 5, 3.5, more than 3.5. That's a big difference. Okay, and one, I'll just, because only few minutes left, so I'll just go over the things very, very very, very basic names only. Okay, so minimal changes is for kid, and then the minimal changes are like basically all you need to know is like the few effacious the podocyte. Effacious podocyte, minimal changes. Okay, that's what we need to know. So the reason they call it minimal changes is if you're looking at the microscope, right? You don't see any difference. It just it looks like normal. But if you see in the electron microscopy, only if you see the electron microscopy, you will see the, oh my God, my podocyte is messed up. Podocyte means epithelial cells. Epithelial cell means that it's not facing the blood vessel. This is a tubule, urine. Okay, this is a urine side. Okay, so only detected by electron microscopy, not regular microscopy. Okay, that's the important thing. And then the focal segmental glomerulonephrosis, like I said, picture slide, only the part of the glomeruli. This is glomeruli, only this part, only this part. Okay, so that's the focal FSGS, sometimes FSGN. Anyway, so this one is the punishment disease. So what I mean is that punishment, something you did something wrong, then that's why you gotta like punishment right now. So this is just my way about understanding it. That includes like HIV, and then IV drug users, IV drug users, and some kind of interference treatment. Why did you do that? I mean, of course it's treatment, but it's the basically you did something wrong. You didn't have to do the drug, but you did. You didn't have to do the HIV, but you did. So interferon, you didn't have to do it, but you did use it. So that kind of thing will cause the FSGN. Because of this racial uh, racial thing. So I don't want to mention this. I kind of hate to mention this, but it happens only mostly in African American and Hispanic. Okay, that's also the kind of FSGN key point. Okay. So, and then the membranous nephropathy, what you need to know is that this is most popular type of the disease. And that let me see, that's something you need to know. And another thing is that this is immunofluorescent. What does immunofluorescence mean? Immunofluorescent means that if something to do with the immune complex, immune system causing problem, right? So in order to detect if in order to detect this, we kind of tie immune cells, okay, immune cells, and then you do the you do the like the stain with the immune cells, and then you take the picture. Then they kind of ray the kind of special kind of like radiation. Then it will appear only immune cells appear with green color. Okay, so that will prove that, oh yeah, there's some immune reactions going on, right? So that's how immunofluorescence is what the showing. All right. So if there's like the linear fashion, and that's very specific for the like good pasture syndrome. Good pasture, linear, the immunofluorescent. Because what happens is that this is a basement membrane against the antibody against the basement membrane. So basement membrane will be damaged due to the immune cells, your body's immune cells. Okay, so that's why you will see like this kind of shape. Although this doesn't look linear to me, but the if you look at like magnified, like if you magnify this, it will be just a straight line here. Okay, that's what I mean. So there are other things in here. I just included for I couldn't finish everything, but that's probably and then I hope you can just read it. This is like a very important. Only the topics that are important to the nephrology I included in here, so you can look at it later on yourself, and then we'll continue the discussion with the biostatistics at 1 o'clock. All right. So I will just finish this in now, and then we'll meet at the 1 o'clock. All right. Okay, so see you later and see you at 1 o'clock.
Thank you. Thank you.
All right. Okay, bye-bye.
Thank you.
No problem. Stop.